Good afternoon, class. My name is Mark Weintraub. I'm going to be your instructor for today. Today's lecture, we're going to talk a little bit about physics, specifically photons' interactions with matter, typically any matter or a patient's body. There are 5 different types of interactions with photons and matter. From least to greatest, we have coherent classical scattering, Compton scattering, photoelectric absorption, pair production, and photodistinction. The 2 higher sources that we don't use in diagnostic X-ray are pair production and photodistinction. Compton and photoelectric, we set the contrast that we use on our image. Let's do a brief review before we get into the interactions of photons with matter. Electromagnetic radiation interacts with structures similar in size to the wavelength of radiation. Higher the energy of an X-ray, the shorter the wavelength. Low energy X-rays interact with the atom. Moderate energy X-rays interact with the electrons. Higher energy X-rays interact with the nuclei. Get into photon interaction with matter. Let's start off from lowest to greatest. So we have coherent scattering, aka classical. X-rays with low energies 10 to 30 keVs. Indecent X-ray photons interactions with the atom causing it to become excited. Atoms release the excess energy as a scattered X-ray with a wavelength equal to that of the indecent X-ray. Scattered X-ray exits atom in a different direction from the indecent X-ray. Change in direction without change in energy. Coherent scattering is not important to X-ray and contributes to noise or fog. Let's discuss the second lowest interaction with matter, Compton scattering, aka incoherent. An indecent X-ray photon ejects orbital electron in outer shell and is defleted. Ejected electron is referred to as a recoil electron or Compton electron. Atom that is ejected is ionized, therefore it has a positive charge. Probability that X-ray will interact with Compton is inversely proportional to X-ray energy, directly proportional to mass density and part thickness. Compton is independent from an atom's atomic number. Compton provides no useful info to an X-ray image, reduces contrast, adds fog, and contributes to diagnostic scattering, especially in fluoroscopy. The last interaction with matter I want to discuss today is photoelectric effect. It's when an incident X-ray photon ejects an inner shell electron and is absorbed. The outer shell electron drops to fill a void, creating low energy characteristic X-rays. The photon ceases to exist and the atom is ionized. This cannot occur unless energy of the incoming X-ray is equal or greater than the binding energy of the orbital electron. At a lower kVp, we have more photoelectric interaction than Compton, which results in better contrast but more harmful for the patient. As kVp increases, photoelectric decreases with lower contrast but better for the patient dose, but bad for the image. As I stated before, Compton scattering and ionization is very important. More matter equals more scatter. Here is a short video just explaining interactions with matter and just about all types of interactions with radiation and exactly how it affects the image and the patient.
Buddy, welcome back. This is the last video on radiation interactions. Here we'll be talking about Compton scattering. This is the most common but the least desirable photon interaction. So here's what happens. The X-ray photon enters an atom in the body, and the X-ray photon energy is partially absorbed by a loosely bound outer shell electron. This results in the electron being knocked out of its orbit, which we call ionization. The electron is commonly called a Compton electron because it was created by Compton scattering. The rest of the photon energy immediately exits the atom as a scattered photon. It has less energy than the original photon and it's going in a different direction. That's why we call it scatter. So with Compton scattering, it's a photon in with an electron and a scattered photon out. Make sure and understand how Compton scattering is different from the other interactions. With photoelectric effect, This interaction takes place in an inner shell electron, and it results in only an ionized electron. There's no scattered photon. Coherent scattering is also different. This occurs when the incident photon interacts with the entire atom. The energy of the photon is temporarily absorbed and then released as a scattered photon. There's no ionization, no free electron, and no biological harm. Once again, Compton scattering occurs when the incoming photon interacts with an outer shell electron. This energy is absorbed by the electron, which causes it to be knocked out of its orbit. At the same time, a scattered photon is also created. So what are the effects of Compton scattering? Remember the three areas that we should be concerned with: patient dose, the bystander dose, and image quality. Compton scattering affects all three areas, and none of these effects are good effects. We'll start by talking about the patient dose. The effect of Compton scattering on patient dose is not good. Remember that Compton scattering does result in ionization. So this free electron that gets created crashes through the surrounding tissues and cells and results in biological damage in the body. The scattered photon can also be absorbed in the patient's tissues, which causes even more harm and more dose to the patient. All of this results in an increase in the patient's dose. Compton scattering also has a negative effect on the bystander dose, such as the radiographer. The reason this happens is because Compton scattering, according to its name, creates scatter. This scatter sometimes strikes the image receptor, but it very easily can strike the radiographer. In fact, Compton scattering is the #1 source of technologist dose. Last of all, Compton scattering also has a negative effect on the image. So why is that? Compton scattering, of course, creates scatter, which in turn decreases the image contrast. Remember this principle. The combination of photoelectric effect and transmission creates what would otherwise be a high contrast, high quality image. And what we mean by this is there's clearly visible differences in the shades of gray. Compton scattering, and really any kind of scattering, adds meaningless noise to the image. When we add scatter, such as Compton scatter, to the image, this results in an overall decrease in the image contrast. So when does Compton scattering occur? Remember this principle. More matter equals more scatter. For example, part thickness. With more matter in the way, more photons interact by Compton scattering. This is the main reason that larger patients, as in the example to the right, have more scatter and therefore lower image contrast. More Compton scatter is created in the thicker patient. There's more matter, therefore more scatter. The same idea applies to part density or tissue density. This refers to the amount of matter packed into the space of the tissue. The chest is mostly full of air, which is lower density, which means there's less matter and less scatter. The abdomen, though, is approximately the same thickness, but much more dense. This means there's more matter, more scatter, and the overall image is going to be lower contrast. One more way we apply this principle is in regards to the field size, or the amount of collimation. If we decrease the collimation, or use a larger field size, there's more matter being exposed, therefore more scatter and lower contrast. One more factor that influences the amount of Compton scattering taking place is the beam energy, which of course is controlled by the KVP. If we increase the KVP, this proportionally increases the amount of scatter and therefore decreases the total image contrast. The ideal situation would be to have as little scatter radiation as possible. So how can we reduce the amount of Compton scatter? Consider these factors. We could decrease the part thickness. We do this by compressing the patient if possible. We would also want to use the smallest field size or the most collimation possible. And last of all, when we can, we'd want to use a lower KVP. All of these factors together decrease the amount of Compton scatter taking place. Obviously, this is the ideal, but sometimes this isn't possible. Here's a summary of Compton scattering. Compton scattering occurs when the incoming photon interacts with a loosely bound outer shell electron. The electron is going to be immediately knocked out of its orbit. This process is called ionization, and the free electron is sometimes called the Compton electron. The remaining energy leaves the atom as a scattered photon, sometimes called the Compton photon. A few more principles to remember. Compton scattering occurs at all energy levels, but it becomes the predominant or the main interaction at high energies. Compton scattering increases the patient dose because of ionization. It increases the bystander dose because scatter is being created. And last of all, Compton scattering decreases the image quality because it decreases image contrast.
As discussed in the last slide, KVP plays a big role in photoelectric absorption. As technologists, we go by a KVP chart. These are the recommended dosage that we use for each body part. For skull, we usually range between 70 to 80 kVp. For shoulder, we do 60 to 75 kVp. Ribs, 60 to 70. Thoracic spine, 70 to 80. Lumbar spine, 70 to 80. Abdominal, 70 to 80. Pelvis, 65 to 80. Hips, 65 to 80. When you're using smaller areas such as the wrist and the hand, you usually want to do between 50 and 55. For fingers, 50. As we go up to the forearm, 60 to 65. Humerus, 60 to 70. Scapular, 60 to 75. And then as we go down the body, the knee, 60 to 70. Femur, 65 to 75. Tib fib, 60 to 65. Ankle, 55 to 60. And foot, 50 to 55. Using these accurate KVP measurements, you could reduce patient dose as well as have a great image. Attenuation, what is it, and how does it affect various tissues? It's any reduction of energy of primary photons. It's the reduction in number of primary photons in the X-ray beam through absorption and or scattering. Scatter is the deviation from the intended pathway. Various tissues are more sensitive than others, which can easily have a greater effect by radiation. To keep a value within limits, we use a tissue-weighted factor. This accounts for the risk of the entire organism brought on by radiation of individual tissues or organs. This calculates effective dose to radiosensitive tissues. A radiographer uses various techniques to minimize exposure to these tissues. As we discussed before, scatter radiation is not good for the technologist or the patient, so we live by a term called ALARA, as low as reasonably achievable. This means time-distance shielding. Spend less time around the area of the radiation, further distance from the radiation source, and shield everyone around you. You, the patient, everyone. Also, we shield mostly the reproductive organs. This will ensure that the patient will be safe during the X-radiation time. Let's do a brief breakdown of how radiation absorption looks on film. Bones are more likely to absorb radiation. This is why they appear white on the image. Soft tissue, fat, and muscle allows more radiation to pass through the bone. That's why these structures will appear gray on the image. Air containing structures like lungs allow more radiation to pass through these structures. That's why they will appear black on the image. As our lecture comes to an end, I want to discuss the types of tissues and atomic numbers. I also want to do a brief overview of what we discussed today. So, for human tissue, we have muscle soft tissue, which is 7.4, fat is 6.3, bone is 13.8, and lung is 7.4. As X-ray energy increases, fewer Compton and photoelectric interaction transmits through tissues. As tissue atomic number increases, no change in Compton, but photoelectric interactions increase as less transmission through tissue. As tissue mass density increases, proportional increase in both Compton and photoelectric along with proportional increase in transmission through tissues. Thank you and have a very good day.